For a tiny organ, the pituitary gland carries outsized responsibilities in the human body. The size of a pea, the so-called master gland, produces vital hormones that regulate many important bodily functions, including growth, stress, thirst, and even reproductive development. So it only follows that when things go awry with the pituitary gland, the body can suffer many other problems. Dr. Garni Barkhoudarian is a director of the Pacific Pituitary Disorders Center at Pacific Neuroscience Institute, and he joins us today to discuss the positive parts and the pitfalls of the pituitary gland. Christine, one of Dr. Barkhoudarian's patients, also joins us to share her story of the long and arduous road to get her pituitary tumor diagnosed and the happy ending she experienced when Dr. Barkhoudarian finally removed the tumor. Hi, welcome to the Think Neuro podcast from the Pacific Neuroscience Institute. I'm your host, Dan Faust, and I'm very happy today to be joined by Dr. Garni Barkhoudarian, the director of PNI's pituitary practice. And Dr. Barkhoudarian, could you introduce yourself or tell us a little bit about what you do at PNI?
Yeah, hi, thank you so much, Dan. My name is Garni Barkhoudarian. I'm a neurosurgeon. I have training in endoscopic and pituitary skull-based surgery, and I did my fellowship at the Brigham and Women's Hospital, part of the Harvard system, with Dr. Ed Laws, which is one of the main pioneers of endonasal surgery for pituitaries and also endoscopic endonasal surgery. And I am the co-director of the Pacific Pituitary Disorders Center at Pacific Neuroscience Institute. And I have a profound interest in the interaction between the pituitary gland, the brain function, brain health, hormonal issues, as well as the tumors that disrupt them and require treatment and surgery.
Great, thank you. And I know we're going to be getting into it and talking about the importance of hormones and the brain and how that all interacts. And I want to start with your fellowship with Dr. Laws, because I think he taught you something very important to consider about that field.
Dr. Laws is just an icon in our field, and one of the few people who was president of both of our national organizations, as well as American College of Surgeons. So that's saying something. And had, I think, to date, the most pituitary operations by a single surgeon. I think 6,500. He's since retired, just recently, actually, and but has contributed a tremendous amount with regards to the understanding of these pituitary tumors, how they behave, how they interact with the pituitary gland, how the pituitary gland functions overall, as well as nuances in surgical applications with regards to how to get to the tumor, how to take it out safely, how to deal with complications, including minor complications that can be a bit of a nuisance to major complications that could be life-threatening. And on top of this all, Dr. Laws has contributed tremendously to our neurosurgical and pituitary literature, and even currently continues to publish, which is just phenomenal and amazing. And so he was very instrumental teaching me the different surgical approaches. He also taught me that it's never too late to innovate and to try new things. I think he started to do endoscopic pituitary surgery in his 60s, which many think is a young man's sport. So really impressed to see somebody pivot from what he was used to where he brought in endoscopic surgery in the 90s and the early 2000s. And one thing that's really key and important to our conversation today is he taught me to really respect the pituitary gland. I will admit that prior to my fellowship with him, we would think of the gland as just something in the way, and we wouldn't treat it with the gentle white glove treatment that we really need to do. And keep in mind some of the hormonal challenges that can happen after surgery. And so I think that's a key thing that I learned from him, and I continue to incorporate in my practice today.
And my recollection is there was also something about take ownership of the endocrine system, that don't just rely on an endocrinologist, but the surgeon has a lot of responsibility in that field as well.
I couldn't agree more. I think the surgeon should not be considered just a technician. To be truly involved in the management of these pituitary patients, you really need to understand the physiology of the pituitary gland. You need to understand the pathophysiology of how these tumors affect pituitary gland function, as well as the body and all the various organs that they can address and cause problems with. And then also post-operatively, how to manage hormonal challenges, both in the hospital and out. And we've been very lucky and blessed to work with amazing neuroendocrinologists, but not everybody has access to people with that expertise. And so I think as a surgeon, you really need to understand that if you're going to operate on pituitary patients. And if you have a younger or less experienced endocrinologist, help guide them in the management of these pituitary tumors, particularly with regards to up-to-date medical management, things that have been set forth by the guidelines of various societies. I think that's really a key part of that. And so part of my fellowship was an endocrinology fellowship. And in our clinic, we had Dr. Whitney Woodmansee, who is an amazing neuroendocrinologist herself. And we were seeing patients together. And that couldn't have been more of an enriching time, because you learn just a tremendous amount, things that otherwise surgically we don't think about, because I'd rather just focus on the technical side. But it's such an important part. And I truly appreciate that now in practice for almost 15 years, it's an important part of what I do.
Oh, fantastic. And so maybe the way to start this conversation is by letting you give us a little primer on the pituitary gland, the so-called master gland. What does the pituitary do, and why is it so important?
This tiny little gland deep in your brain. Why is it so important? Why do we care so much about it? And also, why do all these tumors occur that can become problematic? So the pituitary gland, as you said, is a master gland. It is the master gland of the body, and it's one of the interfaces between the brain and the endocrine system, or the brain and the hormones that the body produces. It doesn't govern all hormones, but many key hormones. And so when we think of the pituitary gland, we have two parts to it: the anterior pituitary gland and the posterior pituitary gland. Those are, in general, how we should think about it. And I'll talk about the posterior gland first because it's easier to talk about. Posterior gland develops from the brain. So as the brain is developing and coming down into the skull base, it's an extension of the brain that forms the posterior pituitary gland. The anterior pituitary gland develops from the roof of the mouth. So what the stomadeum, which is what it's called, and that develops and grows up, and they meet together in the area of the pituitary and form what we know as a pituitary gland. But that posterior lobe is actually extension of the brain. It has nerve fibers in there and has axons and direct connections there. And it does release two specific hormones into the circulatory system. One, which we'll talk about briefly, but really in passing, is called oxytocin. We rarely think about oxytocin in our day-to-day lives. It is a hormone that is involved in the contraction of the uterus during delivery of childbirth. And so it's a unique hormone that we really only use during childbirth. The other hormone that is produced in the posterior lobe is called antidiuretic hormone, or vasopressin is the older name. So ADH is typically what we call it these days, antidiuretic hormone. And that's a hormone that governs fluid balance. And it governs our thirst center as well, to make us want to drink fluid. So if we have too much of this hormone, your kidneys will retain fluid, and you're going to have too much water with respect to the other electrolytes. It can even cause low sodium and other electrolyte levels, which can cause problems. If you have too little of this hormone, you get what's called ADH deficiency, or what used to be called diabetes insipidus. And that would cause you to urinate a lot because your body is dumping fluid, makes the urine very dilute. And as such, your blood actually gets very concentrated and your sodium level can get very high, what's called hypernatremia. And that could also be life-threatening or at least cause a lot of symptoms. And so in some cases, we see this hormone affected by tumors and other pathology in the pituitary gland. Not commonly, though. It's usually something we see after surgery that can be disrupted from us manipulating that part of the gland. And we have to pay close attention because either of those two things can occur after surgery, which can affect cognition as well as some systemic symptoms, and in some cases could be life-threatening. So that's the posterior lobe. It's a simpler part of the pituitary gland because literally it's just the brain extension of the brain, and it releases the hormones directly into the bloodstream and it goes out and does its job. The anterior gland has a number of hormones that it produces, and it's actually regulated by another structure in the brain called the hypothalamus, which is situated right above the pituitary gland. And the hypothalamus actually has hormones that it makes that circulate down to the pituitary gland and through what's called the portal system. And then it tells the pituitary gland to make hormones. And then the pituitary gland hormones go down into the body, into the rest of the body, and control certain other target structures. And we'll talk about those glands, or it actually has effects on the end organs, and we'll talk about that as well. And then what happens is they typically will release another hormone or another signal to feed back to both the hypothalamus and the pituitary gland in a negative feedback loop that causes them to get regulated. So that's called the hypothalamic pituitary axis, HPA. And that helps us regulate the hormone production. And so there are a number of hormones. The most important is called adrenocorticotropic hormone, or ACTH. And that is regulated by the hypothalamus by something called CRH, or corticotropin releasing hormone. And that, once it's produced, circulates down to the adrenal glands. And the adrenal glands make a number of hormones, but this particular hormone affects cortisol production. So it's the endogenous steroid of the body. This is really critical for day-to-day activity. It's important for fighting stressors like a bad illness or a car accident. And when people lack this hormone, you can get what's called Addison's disease or Addisonian crisis, and that can be life-threatening. You can get significant fatigue, weight problems, and even cognitive issues. And so that's one of the most important hormone systems in the body. So that's called the adrenocorticotropic axis. The next hormone, which is quite important as well, is the thyroid hormone. So the thyroid gland that we all know makes the thyroid hormone, thyroxine, and that is involved with metabolism. So it affects every cell in the body, and it can ramp up or ramp down cell metabolism. The pituitary gland makes TSH, which is thyroxine stimulating hormone or thyroid stimulating hormone, and it's regulated by the hypothalamus, similarly by TRH or thyroxine releasing hormone. And those all induce each other, and there's a negative feedback loop with the thyroid hormone. And so in some cases, we can have high thyroid levels, in some cases, low thyroid levels. If you have low thyroid levels, and this will come in apropos to our further discussion later, people can get fatigue, weight gain, cold intolerance, and in some cases, cognitive dysfunction and dementia. So this is a key part of its relationship with the brain and cognition. Another hormone system is the growth hormone system. So the pituitary gland makes something called growth hormone. Many of us have heard of this. Growth hormone acts on every organ in the body, every cell and tissue type in the body. And it's really about growth. It's about, during childhood, actually helping a child grow. And after one reaches adulthood, it maintains muscle mass, bone health, and overall general function. People who have low growth hormone have been shown to have poor quality of life. So that's growth hormone deficiency is a real issue, and it can result in some challenges, not really cognitive, but more quality of life issues. And then the final, the fourth axis that I want to talk about is the gonadotrope axis. So this is the relationship with the pituitary gland and either the testicles in men or the ovaries in women. and it's involved with the ovarian cycle in women. I won't go into detail about that, but both estrogen and progesterone production, as well as ovulation, periods, and ultimate pregnancy. And then it's also involved on the male side in testosterone production and sperm genesis. So that's also regulated by two hormones from the pituitary gland, FSH, which is follicle stimulating hormone, which helps induce follicles to form ovules and for help for pregnancy, and LH, or luteinizing hormone, which is the later cycle in ovulation, and it also makes testosterone in men, or it governs testosterone production by the testicles in men.
Dr. Barkhoudarian said another hormone, prolactin, is a weird hormone altogether. While it helps women make breast milk after childbirth, and can also help prevent new pregnancies right after a child is born, in cases where it's abnormally produced, it can cause infertility and, here comes the weird part, can even cause men to produce breast milk. And that's not the only strange aspect, as Dr. Barkhoudarian explains.
And here's the other weird thing about it. So as I mentioned, there's a negative feedback loop. The interesting thing about the negative feedback loop is that the hormone made in the hypothalamus that governs the pituitary to make prolactin is dopamine. And so if the dopamine connection between the brain and the pituitary gland is blocked, then it makes more prolactin. So it's a negative feedback loop, which is a little bit different how the other ones work from the brain. So people who are on dopamine agonists actually have low prolactin. So Parkinson's disease would be an example of that. And people who take medicines that block dopamine, like antipsychotics, tend to have high prolactin. And so that's another interesting, unique physiologic aspect of prolactin. So those are the hormones that govern the pituitary gland, and you can see how they affect the entire body. There are other hormones that the body makes, like insulin and adrenaline, that are completely independent, but you can see how impactful the pituitary gland is throughout the body.
A lot of responsibility for a little gland.
A tiny 1.5 centimeter little pea-shaped thing and deep in your brain.
And I gather tumors in that area then are what can cause a lot of problems. And I think you've alluded in many of those cases either to too much production of something or too little production, and either one can be a big problem.
Yeah, so tumors, you mentioned perfectly, can either cause no symptoms with regards to pituitary gland. Certainly that's the most common situation. But if it does impact the pituitary gland, it can affect either overproduction or underproduction of these types of hormones. And so, typically for large tumors, macroadenomas, they can cause gland compression, and you can see one or more of these different pituitary axes, the HPA axis that I mentioned, one or more of these axes get affected. And so you could see more commonly low testosterone or infertility in women. So that's the gonadotrope axis. You can get low growth hormone. That could affect quality of life. You can get low thyroid production. So that's also just fatigue and weight gain and some of the other things we talked about with cognitive issues. And you can get low cortisol level, again, causing fatigue and low cortisol symptoms like hypocortisolemia and Addison crisis. On the flip side, each one of these different cell lines in the pituitary can erroneously overproduce hormones. And so there's three common ones that can occur. The most common type is called a prolactin secreting tumor, or a prolactinoma. So prolactinomas make too much prolactin, as you can imagine, way higher than you would see with a medication side effect. And that would typically cause sexual dysfunction in men or infertility in women, or both. And it can result in addition, the breast milk production. Also, with large tumors, it can also cause the rest of the gland to work poorly. So that's also an issue. The interesting thing about prolactinomas are that they could be treated with medicines. 90% of these tumors respond to dopamine agonists, like cabergoline being the most common. And that allows the tumor to shrink down without surgery, shrink down and go away. And you can actually, in some patients, cure them or at least get them into long-term remission with just a medicine that you can take a couple times a week. So that's pretty impressive with prolactin secreting tumors or prolactinomas. And those are the most common hormone secreting tumors. The second most common hormone secreting tumor causes a condition called Cushing's disease. Cushing's disease, where you have high cortisol levels circulating in the body due to high adrenocorticotropic hormone, or ACTH. The diagnosis of that is a little bit nuanced, so I don't think this is the right venue to go into that. But if you have too high cortisol levels, you can get weight gain in a particular pattern, including behind the neck and above the clavicles and the central adiposity, easy bruising, thinning of the hair, acne, and it can also elevate your sugar and get diabetes or worsen diabetes. It can elevate your blood pressure and get hypertension or worsens that as well. It can cause easy bruising, brittle bones. People get long bone fractures like hip fractures, et cetera. And it can affect cognition. And one of the images that we have is a patient that looks like they're 80 on the MRI because their brain is atrophied, but they're actually in their 20s. And that could happen from chronically high cortisol levels. It can also affect cognitive function, emotional function. So people can get psychotic from that high cortisol levels, and they can get a lot of anxiety as well. So it's a major issue, and that's treated primarily with surgery to take the tumor out. And if surgery doesn't work, then we treat those with medicines. There are some really good medicines out there, and we won't go into the details about that, but there's some various ways of tackling that. And radiation also has a role in some patients. And if we lose all options, then we actually just take the adrenal glands out and then deal with not having adrenal glands. That's the second most common hormone-producing tumor. And the third most common is a growth hormone-producing tumor causing acromegaly in adults and gigantism in younger adults and children. So that's where you have high growth hormone. And we'll talk about the kids first. They basically don't get a stop notice where they have to stop growing. So you start to see kids getting into their 7 feet and even 8 feet tall, very large. Andre the Giant being a very famous example of that, or the actor that played Jaws in the James Bond series also had gigantism. You might see a few basketball players who have gigantism that we've certainly seen and even operated on. So that's certainly maybe a positive side effect. But one of the challenges with prolonged exposure to growth hormone is it can affect the heart. You get what's called hypertrophic cardiomyopathy, so the heart doesn't function as well. Some people actually get sudden death from that. It can affect your also blood pressure and diabetes, similarly like Cushing's disease. And then in adults, when they get them, you get a acromegaly. And acromegaly, so you don't have the growth, but you still have the facial changes. So you get the really thick brow, large nose, and large tongue. So people tend to snore or get sleep apnea. People's rings stop fitting because their hands are growing. They stop. Typically, I have a patient who's married who just doesn't have a ring on because they don't fit anymore. Their belt size gets bigger. Their shoe size gets bigger. They get skin tags and other dermatological changes. So that's acromegaly. And that could also not only have physical changes, but it can affect your quality of life, and it could affect your length of life. And we know patients who have Cushing's disease and acromegaly lose about 10 years off their life left untreated. So it's an important thing to identify and tackle. And the sad fact is, because these are subtle changes that take years to develop, there's typically a lag of about, on average, 7 years from the time of symptom onset till we actually make a diagnosis and then start treatment.
I was going to ask about that. I think with many of these hormonal diseases or either deficiencies or overproduction, it can be hard to get a diagnosis. And I assume it's just as critical in this area as it is in so many others. The sooner you can figure it out, the sooner you can treat it.
Absolutely. Yeah, it's very challenging. Some of that comes from lack of awareness. Some of it comes from a patient just not thinking about their symptoms until it's way far progressed. But we do have clinicians who maybe they know about it, but it's not really in the forefront of their minds, in the back of their mind. And it may take a few visits for them to even start to think about, maybe I should do a workup for Cushing's disease because I can't really manage the blood pressure, that kind of thing. So for me, it might be very easy to say, yes, that person has Cushing's disease or has acromegaly. I can spot them from across the room. But for most patients, most people, it's not that easy to do. And it's because it's just not in the forefront of their mind like it is for me. So
I think they're not that common, I assume.
They're not that common, and they overlap symptoms with so many other diseases. And so that's a challenge in its own right. But I will say we have amazing physician groups or patient support groups, that tackle these issues and get the word out, not just to the physicians and caregivers that are seeing these patients on the front line, but also to the patients themselves. So now it's very easy to just type in your symptoms in, Chat GPT or something like that. And it'll tell you, you should be at least considering Cushing's disease or something like that. And so I think that's a good example of how technology can help us in this process. But the Cushing's Disease Society or the Cushing's Society, the Acromegaly Society, there's other disorders that really have these these dedicated societies, and they're very helpful in getting the word out, and also a place for patients to come and learn from each other and help each other out as they tackle what is otherwise somewhat of a rare diagnosis.
I thought it might be useful if you wanted to think about, say, just, we've got so many different things we're talking about and such a lot of ground to cover. One example of a surgery that you do, or at what point do you realize that this problem is being caused by a tumor, and then what is involved in tackling that tumor?
Yeah, so we make that diagnosis well before a patient comes to the operating room. I will say the best place for a patient to get care for a pituitary tumor is at a pituitary center of excellence. And a pituitary center of excellence means a place that does a high volume of pituitary operations and sees probably 10 times as many patients to get to that point. So they have an expertise in assessing these patients, doing the workup. It's not one person, it's a team approach to management of these tumors.
The Pacific Pituitary Disorders Center at Pacific Neuroscience Institute in Santa Monica is one such pituitary center of excellence. PNI's team of pituitary disorders specialists treat all types of pituitary tumors and related conditions. Because of that approach, PNI patients have shorter hospital stays and better long-term outcomes, and PNI can treat aggressive, atypical, and recurrent pituitary adenomas and related tumors. Dr. Barkhoudarian walks us through the various members of the team and their roles.
So you need a neurosurgeon, of course, but you need an ENT surgeon to get us to the area where we want to go to, and also to deal with some of the postoperative issues. The neuroendocrinologist is a key member of this team to help make the diagnosis, manage the patient, and also perioperatively and postoperatively. But also we need a very astute neuroradiologist to help us with the imaging diagnosis, neuropathologists to help us understand what we've taken out when we do that, because there are definitely zebras out there that can be very challenging to understand. And you need to have somebody who has the expertise or the understanding to look elsewhere. Also radiation oncology for certain cases, and other ancillary specialties like endocrine surgeon to take out the adrenal glands, or a geneticist to help us with unique genetic syndromes that can occur with various pituitary tumor syndromes. And then we also need the patient support team. As I mentioned, the patient support group locally is very helpful in having patients talk to each other and learn from each other. And our nurse navigators, our patient navigators, typically our nurse practitioners like Natasha Cueto or Amy Eisenberg in our team, who help a patient get through all this challenging time, comfort them and kind of tell them, hey, this is the right thing to do. And also guide them through the preoperative workup, the diagnosis, and postoperatively as well. So really, really key part of our team. And our team would fall apart with the loss of any of those individuals, let alone more than one. So to answer your question, say we see a patient, let me give a good example that I just saw recently. I had a patient young lady, 30-something, who was trying to get pregnant and couldn't get pregnant. She ultimately sought the expert advice of a reproductive endocrinologist. And he, who has done a lot of these, gets a routine set of labs, including a prolactin level. And this prolactin level in this patient was just somewhat elevated. It was about twice the upper limit of normal, so not dramatically off the charts. But he still did get a pituitary protocol MRI, and that showed a cyst in the pituitary gland, not a tumor, but a cyst. And the cyst was causing pressure on the pituitary gland. And we recognized that this was the cause of the elevated prolactin, which was likely the cause of her not having ovulations and not being able to get pregnant. Operate on her. Within a day, her prolactin gets to normal levels, and she's now proceeding with pursuing pregnancy. So that's one example of how we can see patients come through and how we can help them.
Christine is another of Dr. Barkhoudarian's patients, and she suffered for years with a series of serious health problems before she was able to get a diagnosis and treatment. It was only when she started seeing a doctor at one of PNI's partner hospitals, Providence St. John's Medical Health Center in Santa Monica, that she had the brain MRI that revealed the pituitary tumor that had been wreaking havoc with her health. Dr. Barkhoudarian and his team removed the tumor and continued to treat Christine, who agreed to share her story with us.
So it was probably back in about, I'd say 2008, 2009, I started feeling kind of out of sorts. Brain fog, not really myself. I've always been a really big go-getter. My family has a ignition lead repair station. We do manufacturing now, but at the time we were doing repair and manufacturing, and I was working there, and I was always like really on the go, just super busy. And I just felt so tired and kind of out of sorts. And it really wasn't until I would say about 2010, I had taken on a job because, the economy was kind of hard then. I took on a job babysitting for triplets. And so that would wear anybody out. So I just kept chalking it up to, I'm just exhausted. I still had my normal job. Plus I was being a nanny. But I would get these kind of like odd, like headaches. I couldn't really describe them. But I just, chalked it up to the stress. And so what really happened was I went to a trip to Alaska with a church group. And while I was there, I just, again, felt really funny, not really myself. But I was like, I don't know anybody here. I'm just nervous. I'm just anxious. And while I was in Alaska, all of a sudden, out of nowhere, I started getting intrusive thoughts. Now, these thoughts were not my own one iota. They were of a very, very dark nature. And it terrified me because that is not how I think. It was almost like somebody else had control of my mind, Dan. And that was very hard for me. I'm like, I'm literally in Alaska with nobody and I'm going crazy.
Christine, how old were you at this time?
Oh, goodness. I was probably in my mid-20s. I'm 40 now, but I was in my mid-20s around this time.
Mm-hmm.
And so I didn't have any children or anything. So I remember looking, my mother's like, you're going to go and be with your pastor. Just, you need to be monitored, basically. And I remember looking in the mirror, Dan, and I didn't recognize that person in the mirror. Now, I mean, people are like, well, that tends to happen. No, I mean, literally, I didn't know who I was looking at. And that terrified me. So I talked to a doctor and they're like, this sounds like you have depersonalization, where you disassociate yourself from yourself because your mind is like going haywire. It's trying to register what is happening to you. So that was terrifying. That was scary. And I still tried to do all the things. I still, my brother was playing high school football at the time. So I'd still go to the games and everything. And then I remember sitting at the game one night and I looked around and I'm like, it felt like as if I was watching a television show. Like I wasn't really there. So I'm like, okay, so now I've got where I don't feel like me or recognize myself, but nor do I recognize anything or really feel like I'm actually there either. And so I talked to the doctor again and he said, oh, well, that's derealization you have. You have both. And I'm like, I have never heard of these terms in my life. So that caused me to completely spiral. I remember I was doing okay and then the insomnia hit where I was not getting any sleep. I was probably getting 2 to 3 hours of sleep a night. And that was if I was lucky. So you can imagine I'm already just don't know what's going on. Now I'm just hit with the fatigue. And this went on for months and months. And and then I started the physical symptoms where I was like, I'd be sick to my stomach, very nauseous. I lost an insane amount of weight very quickly because I really wasn't eating. I couldn't keep any food down. I wasn't really eating, but still more so, my symptoms were completely psychological. So out of desperation, I checked into a clinic and said, I just need some medication to sleep. I'm just that desperate because I'm really not into medication. I mean, I've always been that way. And I go down there and I don't know what I had stated to the nurse to trigger her to check me into a ward. So now I'm being transported to a hospital in Bellflower.
A psychiatric
Psychiatric.
hospital.
I am now on a 72-hour psychiatric hold. I don't know what's going on, but if I stay in here, I'm not going to be able to get the help I need.
Christine was released from the hospital and continued on her journey. She searched online, joining Facebook groups for depression, anxiety, and derealization.
About 2012, the physical symptoms hit.
We're now about 4 years into your ordeal.
Yes, 4 years into it. And the first symptoms were my teeth felt weird, like in the back area, they hurt all the time. My jaw was killing me. I mean, it just the worst jaw pain. So here I'm like, okay, why do I have jaw pain now? Why am I getting these headaches? And then comes the vision problems. And I would notice after these headaches would come that my vision would go blurry all of a sudden too. And it would take a while for it to start focusing back. Also, I will mention too that my friends and my mom noticed probably around the end of 2016, really in 2017, my nose was big. I mean, it started growing. My forehead was very pronounced, like my brow bone stuck out. My lips were huge, but not in a good way. Like my features became very, very masculine looking. The next morning, I get a random call on my phone, and it was a doctor that I had not seen in probably 15 years. It was her clinic. And she goes, hey, we take your insurance now. We're just wondering if you'd be interested in seeing her again. I said, I have nothing left to lose at this point, Dan. I'm like, sure, why not? So this was with the Providence Medical Group. So I see her and she takes one look and she's like, there's something wrong with you. I'm like, do you know how great that was to finally hear those words and be validated that it wasn't in your head, it wasn't psychosomatic? This doctor knew. So she ran some blood work on me and everything.
She was a primary care doctor.
Yes. And so she said, I'm going to send you a referral out to a pain specialist because I told her about the headaches. And at the time, I had been recording these headaches to just say, listen, this is what's happening to me. She goes, I'm going to request a brain MRI on you. So here, Dan, I'm sitting here like, a what? A brain MRI, like what's going on? So I said, okay, I literally have nothing else to lose. I might as well just do it. And I remember she called me that evening and she goes, I just got a call from the radiologist, but you have a pretty good sized tumor and we need to get it taken care of immediately. So here, can you imagine hearing those words? And I'm like, wait, what? Like that. I was back in like dream la la land. I'm like, no, there's no way. There's no way. And I remember, of course, breaking down crying, Dan, because when you hear that, you don't know. And I remember I went into work the next morning after I told my mom and everything, and my dad's in there, and he's like, "Well, what's wrong, honey?" And I go, "Dad, I have a brain tumor." And he goes, "Wait, what?" And he couldn't believe it. He was shocked. Then I get a call from PNI and Dr. Barkhoudarian's office, and they're like, we need to come in, do all the scans, all the pre-op stuff. We're going to take care of this. So I had the pleasure.
And I just want to make sure, because you had been seeing a doctor at Providence and they're affiliated with PNI, and that's
exactly,
why.
which was that in alone in itself was the biggest blessing of the Providence doctors, because I was able to see Dr. Barkhoudarian, Dr. Krause, Dr. Chester Griffiths, Daniel Kelly. I had the most phenomenal team anybody could have ever asked for. And so they scheduled me for the surgery the end of April. And, Dr. B actually thought that I've had Cushing's because of, my symptoms and everything. And I was showing him the videos and the pictures, and he's like, "Oh my." And when they recessed the tumor, and I still had some residuals left in there, and it had wrapped itself around my my optic chiasm, the optic nerve. So I had a cool pirate patch for a little while after after the surgery and everything, and they sent it to pathology, and lo and behold, it was making its own hormones. So it was making its own growth hormone, and my IGF-1 was incredibly high. So he had diagnosed me with acromegaly. And so I was in the hospital for a few days, and then I stayed in a bougie hotel for 10 days after. And I remember, Dan, and I'm not going to get emotional, I'm going to try not to. A few days after the surgery, I remember, brushing my hair and looking in the mirror, and already my facial features had started softening. Already I started looking more feminine. I started looking more like myself. And even my mother said, "Christine, this is," of course with my cool my pirate patch, but just the features started softening. The headaches went away. The cycle regular. It was almost like an instantaneous, my body was like, "Yes, finally." But not really for long, I'm going to be honest. So here I have this out, and I'm feeling great. I'm like, I am conquering the world. I was blessed. I became a 40 under 40 recipient in the aviation industry. So that was amazing that same year, went all the conferences and stuff. So I'm doing good.
Christine's story did not end with her surgery. In many ways, it continues to this day. Dr. Barkhoudarian told us about the importance of the period immediately after surgery. He said a perfect operation can go horribly wrong due to post-operative issues, so the surgeons at PNI really pay close attention to what comes after the operation, both in the hospital and after the patient leaves the hospital. One thing they watch for is when a large tumor comes out, cerebrospinal fluid begins coming out as well. But if the fluid comes out consistently after surgery, it could cause meningitis or severe headaches. By getting patients to get up and move around on the same day after their surgery, that can help prevent the leaking. With pituitary tumors, the surgeons also pay close attention to the patient's hormones. They don't give steroids right away, waiting to see if their body is recovering. They also look at their sodium level in case patients have too much antidiuretic hormone, or ADH. That can cause really low sodium levels that could cause altered mental status, nausea, vomiting, seizures. Or they could lose production of ADH, and their sodium levels can get very high, causing other problems. If patients don't have underproduction, doctors limit them to only about a liter of fluid a day. It used to be 5% of patients wound up in the emergency room with low sodium, and many would get hospitalized. Then Dr. Barkhoudarian's mentor, Dr. Ed Laws, tried limiting fluids, and it worked. After monitoring patients for a week, they can typically proceed as normal. Surgeons are also able to send people home from the hospital remarkably soon after the pituitary surgery, sometimes the same day and sometimes the following day.
On average, our length of stay is somewhere between 1 and 2 days for pituitary tumors. Cushing's disease even, that used to take longer, take 3 or 4 days to figure out if their cortisol levels were normalizing or not. But nowadays, we're even better at that. We can get that to about 2 days. So gone are the days where you keep a patient for a week to 2 weeks in the hospital just to monitor their electrolytes. Mm-hmm. But it does take a team of dedicated individuals to monitor these patients, even over the weekend, to give them that phone call. Hey, how are you doing? Maybe we should get a sodium level check today just to be sure. Have them come back in for that day 5 or day 7 sodium level and hormone level check, and also limit their fluid intake. So that's really key. If we didn't have that, then they would be staying in the hospital.
Well, thinking about Dr. Laws coming up with that, I know that you've also at PNI has innovated and come up with some techniques and things and published papers. I'd love to hear a little bit about what you folks have been able to do.
Yeah, we're very proud of the work we've done over the last 15 years or so, and even before that, before I joined. Dan Kelly, my senior partner, and Chester Griffiths, our senior ENT colleague, really have done a tremendous amount for molding the approaches we do to where we are currently. And we continue to improve on this. We've done a number of things that I think are really key. One thing that stands out, so we talked a lot about hormones. Well, we are going through the nose, and the nose is kind of a dirty area. It also has a number of challenges postoperatively, including congestion, nosebleeds, and even lack of sense of smell, which affects sense of taste. So we in particular, Dr. Griffiths was thinking, what could we do? And thanks to working with Rick Corral, who was our partner previously and is currently at Ohio State University, we developed something called the bilateral rescue flap technique. It used to be, like when I was training, we would go and rip out all the mucosa in the nose on the way, and it was just blasting it open just so we can see the tumor and take it out. That we felt great. The ENT surgeons hate us for that because it causes so many issues. So they said, well, why don't you just make an incision in that mucosa, move them out of the way, push down the area that the blood vessels live so you don't get nosebleeds after surgery, or at least arterial nosebleeds, and push up the area that has the nerve fibers for sense of smell, so they're out of the way. Then you do the operation, get rid of the bone, take the tumor out, and then you put everything back together and then you close things up. And by doing those techniques, our postoperative arterial epistaxis, so the massive nosebleeds that about 5 or 7% of patients would get in the old way, went down to near zero. And patients who were complaining of lack of sense of smell for 6 weeks or 3 months after surgery, that shortened that duration down to about 2 to 3 weeks and quicker and better nasal recovery. So we published that a few years ago. We're very proud about that. That's a quality of life thing that affects patients. As I mentioned, can take a perfect operation and make it very challenging for a patient if you have those types of complications. And those of us who appreciate a fine glass of wine or a good steak or amazing chocolate do appreciate sense of smell. So having that challenge, anosmia or hyposmia, can be a problem for many patients. So paying close attention to that is key. Another area that I think we're quite proud of is the work that my partner Dan Kelly has done in Cushing's disease, identifying the thresholds that we need to get to call a patient cured right after surgery. So we have a whole protocol on that, on how we would approach these. And in some cases, it may show that we didn't get all the tumor out, even though the MRI looks great. The labs tell us we didn't get all the tumor out. We take the patient right back and then go back and take more tumor out. That's something that Dan Kelly did years ago and is now standard of care and part of the guidelines. Another thing that we've done was about safety in the operating room. So we have two major complications that we worry about, one more common than the other. I mentioned the leakage of fluid that we talked about. So we actually have a whole protocol on how we reconstruct the nose. And our leakage rates, our cerebrospinal fluid leakage rates, are one of the lowest in the country as a result, because we pay close attention to it and we do a good job with the reconstruction, but we also have a graded reconstruction system so that, the type of leak and the type of patient are accounted for in how we reconstruct it. So that's something that we published a few years ago. And something we published more recently was in high-risk patients. So patients who have invasive tumors, patients who've had prior surgery where their anatomy is distorted, or who've had radiation, so the tissue may be more brittle and at higher risk of injury. There are a couple of arteries right next to the pituitary gland called the carotid arteries. And these are the arteries that feed the brain. These are really critical arteries. If one were to even nick this artery and get bleeding, it could be catastrophic and often associated with strokes and in some cases death. And so we're operating right by these vessels all the time. And an average surgeon will have this happen in their lives a few times. It happens so infrequently, thankfully. People who do a lot of pituitary surgery will also have this happen probably a little bit more often than the others, but it's still quite infrequent. It may happen once every 5 or 10 years. And in the heat of the moment, when you're dealing with catastrophic bleeding and your camera can't see very well, and the anesthesiologist is telling you that the patient's tanking, it's hard for one to remember every single thing you need to do to fix the problem and to make sure the patient does well. And very similar to what we saw with Captain Sully and dealing with a plane that's malfunctioning, he had the first thing they asked was get the QRH, the Quick Reference Handbook. So they have a checklist for every single scenario, dual engine failure, whatever. So we have a checklist in the operating room for a carotid injury. And we actually have two checklists. One is before we make an incision on the patient, we call a preoperative checklist, that we are having the right equipment in the operating room, which we don't always have for a routine case. The anesthesiologist is aware and they have the right monitoring apparatus for patients, whether it's catheters to monitor blood pressure or to give fluids back. We have blood in the room. We have specific drugs that we need to help manage the bleeding in the room, ready to go at a moment's notice. And we also alert our interventional suite that have to go in through the groin to fix the problem later on. So they're on notice as well. So that happens even before we touch a patient. And then in the heat of the moment, say something like that happens, we have a separate checklist, and our OR nurse knows to run down that checklist and not skip a beat, because if you skip one of those, it might result in a stroke or might result in other injury. And so that's something that we recently published on. And we actually have had a couple of near misses, or as George Carlin would say, near hits. And thankfully, these patients did quite well and were not the carotid artery, but they were still bleeding a lot. And we applied this checklist and everything went perfectly. And we got the patient directly to the angio suite and they got everything taken care of. And it was like clockwork. And it was because we were prepared, and it was because we had everybody on the team at that heightened level of alertness to deal with the problem. So we're happy about all that, and we continue to develop things in the lab, and we look forward to the next big iteration that we're going to help contribute to.
Christine benefited from some of these advances. Doctors reached her tumor via her nose. They had taken fat from one part of her body and used it to patch the area they operated on. While she's been healthy since her surgery, the recovery has not been linear. The hormones that had been wreaking havoc during her low points still needed time to recover their normal function. Christine maintains a positive outlook on life. She is passionate about getting the word out to other patients and even to doctors about pituitary tumors, so no one should suffer as long as she did. And she expresses gratitude for all the things that helped save her, including her faith, her late mother who supported her in all her treatments, and her doctors, led by Dr. Barkhoudarian.
really have to say, like, I owe my life to Dr. Garni Barkhoudarian. I really do. My late mother being persistent, and then my pastor with my faith. And I don't mean to get emotional, but it's an emotional thing to talk about. That I mean, I'm still here to tell my story and my testimony and to hope and to help other people.
Right.
But yes, and I just, for anybody that's listening out there, just know that, try P&I, go to Dr. Barkhoudarian, because that man was a godsend to me and his team, and I can't thank them enough.
As we wrapped up, I asked Dr. Barkhoudarian if, in thinking about all these different hormonal issues in the brain, there was anything people could do in their own lives to stay healthy.
Oh, certainly there are. Number one, before we even talk about pituitary gland and tumors and things like that, there's a lot of quality of life things that affect us. And I'll tell you, as doctors, we're horrible at following our own advice. But I think if you can achieve that, and some of our patients can, it could be very helpful. Certainly a balanced diet, certainly exercise, routine exercise daily. Certain supplements are quite helpful, and there's a whole laundry list of those, which we don't need to get into right now. A couple of areas that are underrated and absolutely critical. One is sleep, getting appropriate, good quality sleep. At least 6 to 8 hours, if not more, is really key. And that has been shown to decrease the risk of Alzheimer's down the line. And it's also shown to improve hormonal function overall. The other aspect is stress and anxiety. Managing your stress and anxiety, decreasing stressors, knowing how to deal with stressful situations or just stress in general. Stress is such a potent component of every disease that we have. And we know that people who are at higher anxiety levels, who have more stress, tend to get more of the problems, more of the heart issues, higher risk of stroke, higher risk of cognitive issues, that kind of the A-type personality. All of that kind of figures into that. So those are 4 things that you can control without even going to the doctor that can affect your quality of life and in turn can affect your hormonal balance and your hormonal activity.
All right. I'm going to get to work on those.
Yeah.
Dr. Barkhoudarian, thank you so much for your time. It's been great talking to you today. I appreciate it.
Dan, it was a pleasure. Thanks for having me.
In addition to Dr. Barkhoudarian's advice on living a healthy life, which will help maintain a healthy brain, today's podcast also provided a lesson in the tricky nature of diagnosing what's happening to someone with a pituitary tumor. Christine's case teaches us that a variety of problems, from headaches and vision problems to menstruation and psychological challenges, may not always respond to the textbook treatment. Patients and doctors should always at least consider the possibility that the tiny pituitary gland, which plays a disproportionately significant role in the body's hormonal system, could have a tumor that is the source of all the trouble. Thank you for listening. Tune in next time to the Think Neuro podcast from Pacific Neuroscience Institute. This is Dan Faust.